Hello and welcome to Unit 4 of Epidemiology Essentials. In these units, we'll be looking at important concepts such as association, causation, and confidence intervals. The most important things to remember about the measures of association are that they could either help us tell us something about the strength of the association between an exposure and a health outcome, or they can help us quantify the absolute excess of the disease that's related to the exposure of interest. Please make sure you understand the measures of health outcome occurrence before you go forward with the measures of association. Those measures of occurrence are the building blocks of the measures of association. So if you understand those, then it will be a lot easy to understand the measures of association. Let's start with an example of measures of association. These examples may be similar to the ones you might have heard in the news. Epidemiologic research on smoking and lung cancer has found that people who smoke are 15 to 30 times as likely to get lung cancer or die from lung cancer as people who do not smoke. This is an example of a measure of association. We will learn more about how to understand and interpret statistics such as this one. Let's talk about the definitions and formulas for measures of association. Measures of association compare the measure of disease occurrence in two different groups. We compare the measure of disease occurrence in the exposed group with that in the unexposed group. Our goal is to see if the disease occurrence is different in the two groups. This comparison can be made by division, or what's known as ratio effect measure, or by subtraction, difference effects measure. For the division, we are comparing relative measures of effect. One key question for this ratio measure is what group you are comparing relative to which other group. For example, the groups being compared in the ratio effect are often exposed versus unexposed. For difference measures in which you are subtracting, you are comparing absolute differences in effect. The ratio measures indicate the relative strength of the association between the exposure and the disease, compared with the absence of exposure or less exposure. The ratio measures indicate the relative strength of the association between the exposure and the disease or health outcome, compared with the absence of exposure or less exposure. This strength of association between an exposure and a disease or health outcome is of greater interest when we are trying to understand causes of a disease or a health outcome. In contrast, difference measures, sometimes called attributable risk, place the magnitude of the association between an exposure and a health outcome in a public health perspective. Difference measures tells us whether the exposure or risk factor is associated with a large number of disease cases or a small number of disease cases. Consider this example. The exposure of smoking has a risk ratio of about 10 for lung cancer mortality, with a risk ratio of about 1.7 approximately for coronary heart disease mortality. However, the risk difference for coronary heart disease is much higher, 125, compared with the risk difference for lung cancer, 43.8. The risk difference can be used to compare the preventative impact of a smoking cessation program on the rates of coronary heart disease deaths compared with lung cancer deaths. A smoking cessation program would have a bigger impact on rates of coronary heart disease deaths compared with lung cancer deaths. To determine whether such an association exists, we must determine using data obtained in case control and cohort studies whether there is an excess risk of the disease in persons who have been exposed to a certain agent. Excess risk can be calculated in the two following ways. The first is the ratio of the risk of the incidence rates, which is the risk in exposed divided by the risk in unexposed. The second is the difference in the risk or in incidence rates, which is the risk in the exposed minus the risk in the unexposed. There is a difference in what we learn from the ratio of the incidence rates compared to the difference in the incidence rates. And that brings us to the concept of relative risk. Both case control and cohort studies are designed to determine whether there is an association between exposure to a factor and development of a disease. If an association exists, how strong is it? If we carry out a cohort study, we can put the question another way. What is the ratio of the risk of disease in unexposed individuals to the risk of disease in non-exposed individuals? This ratio is called the relative risk and is given by the formula the risk in the exposed divided by the risk in the unexposed. This relative risk can also be defined as the probability of an event occurring in exposed people compared to the probability of the event in non-exposed people, or as the ratio of the two probabilities. How do we interpret the relative risk? If the relative risk is equal to 1, the numerator equals the denominator, and the risk in exposed persons equals the risk in the unexposed persons. Therefore, no evidence exists for an increased risk in exposed individuals or for any association of the disease with the exposure in question. If the relative risk is greater than 1, the numerator is greater than the denominator, and the risk in exposed persons is greater than the risk in non-exposed persons. This is evidence of a positive association and may be causal. If the relative risk is less than 1, the numerator is less than the denominator, and the risk in exposed persons is less than that in the non-exposed individuals. This is evidence of a negative association, and it may be indicative of a protective effect. Such a thing can be observed in people who are given an effective vaccine. Here we see a 2x2 table of people who were exposed or non-exposed on one hand, and then on the other side, people who developed the disease and did not develop the disease. So among those who were exposed, the incidence is A over A plus B. And for those who were unexposed, the incidence is C over C plus D. When we take a ratio of these two incidences, we get the relative risk. So we have seen that in order to calculate the relative risk, we must have values for the incidence of the disease in the exposed and the incidence in the unexposed, as can be obtained from a cohort study. However, in a case control study, we do not know the incidence in the exposed population or the incidence in the non-exposed population because we start with diseased people, cases, and the non-diseased people known as the controls. Hence, in a case control study, we cannot calculate the relative risk directly. Another measure of association, the odds ratio, can be obtained from either a cohort or a case control study and can be used instead of the relative risk. Though we cannot calculate a relative risk from a case control study, under many conditions, we can obtain a very good estimate of the relative risk from a case control study using the odds ratio. I'll talk about this more later. So the odds ratio also uses a 2x2 table. So the odds ratio is the odds that an exposed person develops the disease divided by the odds that a non-exposed person develops the disease. The odds ratio is also known as the cross products ratio because it can be obtained by multiplying both diagonal cells in a 2x2 table and then dividing. We interpret the odds ratio just as we interpret the relative risk. If the exposure is not related to the disease, the odds ratio will equal 1. If the exposure is positively related to the disease, the odds ratio will be greater than 1. And if the exposure is negatively related to the disease, the odds ratio will be less than 1. So in a case control study, only the odds ratio can be calculated as a measure of association, whereas in a cohort study, either the relative risk or the odds ratio is a valid measure of association. When is the odds ratio obtained in a case control study a good approximation of the relative risk in the population? It is a good approximation when the following three conditions are met. When the cases studied are representative with regard to history of exposure of all people with the disease in the population from which the cases were drawn. When the control studied are representative with regard to history of exposure of all people without the disease in the population on which the cases were drawn, and when the disease being studied does not occur frequently. Here we see examples of calculations for the relative risk and odds ratio. We see that in the first table, which is on the left-hand side, the relative risk is very, very, very closely approximated to the odds ratio. Now we talk about the attributable risk. The relative risk and the odds ratio are important as measures of the strength of the association, which is a major consideration in deriving causal inferences. We turn to a different question. How much of the disease that occurs can be attributed to a certain exposure? This is answered by another measure of risk, the attributable risk, which is defined as the amount of or proportion of disease incidence or disease risk that can be attributed to a specific exposure. For example, how much of the lung cancer risk experienced by smokers can be attributed to smoking? Whereas the relative risk is important in establishing etiologic relationships, the attributable risk is in many ways more important in clinical practice and in public health because it addresses a different question. How much of the risk of disease can we hope to prevent if we are able to eliminate the exposure to the agent in question? We can calculate the attributable risk for exposed persons or the attributable risk for the total population, which includes both exposed and non-exposed persons. If we want to know how much of the total risk in exposed persons is due to the exposure, we should subtract the background risk from the total risk. Because the risk in the non-exposed group is equal to the background risk, we can calculate the risk in the exposed group that is the result of the specific exposure by subtracting the risk in the unexposed group from the total risk in the exposed group. Thus, the incidence of a disease that is attributable to the exposure in the exposed group can be calculated as incidence in exposed group minus incidence in non-exposed group. We could instead ask, what proportion of the risk in exposed persons is due to the exposure? We could then express the attributable risk as proportion of the total incidence in the exposed group that is attributable to the exposure by simply dividing the previous formula by the incidence in the exposed group as follows. The incidence in the exposed group minus incidence in the unexposed group divided by the incidence in the exposed group. The attributable risk expresses the most that we can hope to accomplish in reducing the risk of a disease if we completely eliminate the exposure. For example, if all smokers were induced to stop smoking, how much of a reduction could we anticipate in lung cancer rates? From a practical, pragmatic point of view, the attributable risk may be more relevant than the relative risk. The relative risk is a measure of the strength of the association and the possibility of a causal relationship. The attributable risk indicates the potential for prevention if the exposure could be eliminated. Now we look at attributable risk for the total population, or population attributable risk. The proportion of the disease incidence in a total population, which includes both the exposed and non-exposed people, that can be attributed to a specific exposure is known as the population attributable risk. It tells us what would be the total impact of a preventive program on the community if the exposure were eliminated. It is given by the formula incidence in total population minus the incidence in unexposed group. Or if we prefer to express this as the proportion of the incidence in the total population that is attributable to the exposure, the formula would then be incidence in total population minus the incidence in the non-exposed group, all divided by the incidence in the total population. Another way to calculate this proportion for the total population is to use what is called the Levin's formula, which is the proportion of the population with the characteristic or exposure multiplied by the relative risk minus 1, all divided by the proportion of the population with the characteristics of or exposure multiplied by the relative risk minus 1 plus 1. That is P into bracket R minus 1 all divided by P into bracket R minus 1 bracket close plus 1. The attributable risk for the total population is a valuable concept for the public health practitioner. For example, the question could be asked, if smoking were eliminated, what proportion of the incidence of lung cancer in the total population would be prevented? The answer is the attributable risk or the population attributable risk. From a public health standpoint, this is often both the critical issue and the question that is raised by policymakers and by those responsible for funding prevention programs. They may want to know what the proposed program is going to do for the community as a whole. How is it going to change the burden on the healthcare system or the burden of suffering in the entire community, not just in exposed individuals? Now, we would like to compare the relative risk and the attributable risk. The relative risk and the odds ratio are important as measures of strength of association, which is an important consideration in deriving a causal inference. The attributable risk is a matter of how much of the disease is attributable to a certain exposure. Consequently, the attributable risk is useful in answering the question of how much disease can be prevented if we have an effective means of eliminating the exposure in question. Thus, the relative risk is valuable in etiologic studies of disease, whereas the attributable risk has major applications in clinical practice and public health. Now we'll move over to the concept of causality. If we determine that an exposure is really associated with a disease, the next question is whether the observed association reflects a causal relationship. Could the observed association be simply due to confounding? Even if an exposure precedes a health outcome, it does not always mean causality, even if it is strongly associated. Let's look at a classic example. We can say carrying a lighter is associated with lung cancer. Carrying a lighter precedes lung cancer. So, does carrying a lighter cause lung cancer? The answer is no. A formal definition of a causal factor may be an event, condition, or characteristic that preceded the outcome or disease event, and without which the events either would not have occurred at all or would have not occurred until some later time. This is definition given by Rothman and Greenland. Causality is not observed, but often inferred. This is known as causal inference. Let's think about what is a causal relationship and why we care about causality. The primary goal of the epidemiologist is to identify those factors that have a causal impact on disease or health outcome development. For example, the causes of COVID-19. Determining causal relationships can provide a target for prevention and intervention, such as face masks or to prevent COVID-19 transmission. It is important to note that sometimes no specific event, condition, or characteristic is sufficient on its own to produce a disease or health outcome. There are a series of criteria that have been developed and refined over the years that now serve as a guideline for causal inference. In 1965, English epidemiologist and statistician Sir Austin Bradford Hill identified 9 factors that constitute the current standards for determining causality. Hill's conclusions expanded upon criteria that had previously been set forth in the United States Surgeon General's 1964 Smoking and Health Report, which was developed to answer the question of whether cigarettes cause disease, especially lung cancer. It is important to note that satisfying these criteria may lend support for causality, but failing to meet some criteria does not necessarily provide evidence against causality. Hill's causal criteria should be viewed as a guideline, not as a checklist that must be satisfied for a causal relationship to exist. So, the first criterion is temporal relationship. It is clear that if a factor is believed to be the cause of a disease or health outcome, exposure to the factor must precede the development of the disease. Temporality is the only necessary criterion for causality. The second is the strength of association. This is measured by the relative risk or the odds ratio. The stronger the association, the more likely it is that the relationship is causal. Next is dose-response relationship, or what we call biological gradient. As the dose of exposure increases, the risk of disease also increases. If a dose-response relationship is present, it is strong evidence for a causal relationship. The fourth is consistency or replicability of findings. If the relationship is causal, we would expect to find it consistently in different studies and in different populations. Number 5 is biological plausibility. This refers to the coherence of the epidemiologic findings with the existing body of knowledge on biological mechanisms and modes of action. Next is analogy, and this is simply similarity with other established cause-effect relationships, which helps to support the argument of causality. For example, previous experience with the effects of thalidomide or rubella infection in pregnancy would lend support for a causal effect of another drug or viral agent in pregnancy with similar but weaker evidence. Another criterion is the cessation of exposure or reversibility. If a factor is a cause of a disease, we would expect the risk of the disease to decline when exposure to that factor is reduced or eliminated. Number 8 criterion is coherence. If a relationship is causal, we would expect the findings to be logically consistent with other knowledge or data. For example, the simultaneous increase in smoking habits and incidence of lung cancer over a period of time would support a causal link, as would isolation from cigarette smoke of factors that cause cancer in laboratory animals. The coherence guideline is more demanding than mere biological plausibility, in that the evidence here must be extensive, cutting across disciplinary lines, all of which mutually support a causal association between exposure and health outcome. Ninth criterion is specificity of the association. This simply states that if a single risk factor consistently relates to a single effect, then it likely plays a causal role. An association is specific when a certain exposure is associated with only one outcome of interest. For example, this one-to-one relationship exists with infectious microorganisms and the disease they cause, as in the case of tuberculosis. This is the weakest of all the guidelines, and some authors suggest it should be removed from the list. For example, evidence clearly demonstrates that smoking does not lead solely to lung cancer, but to a myriad of other clinical disorders ranging from emphysema to heart disease. In addition to assessing the components of Hill's list, it is also critically important to have a thorough understanding of the literature to determine if any other plausible explanations have been considered and tested previously. Note that this is not one of the guidelines cited by Hill, but considering alternate explanations is important because we have greater confidence that potential confounders were adequately controlled when multiple studies address the confounders and still agree in finding an exposure response association. Any conclusion that an observed association is causal is greatly strengthened when different types of evidence from multiple sources support such reasoning. Thus, it is not so much a count of the number of guidelines present that is relevant to causal inference, but rather an assessment of the total pattern of evidence observed that may be consistent with one or more of the guidelines. In concluding this discourse on association and causation, the concepts of relative risk and attributable risk are essential for understanding causation and the potential for prevention. We have discussed measures of risk like the absolute risk, relative risk, odds ratio, and attributable risk. Although it may be a desirable goal to place causal inference on a firm quantitative and structural foundation, at present, we generally do not have all the information needed for doing so. The guidelines set forth by Hill are therefore not strict criteria, but should be considered to be only principles that can be of most value when coupled with reason's judgment about the entire body of available evidence in making decisions about causation. Move over to confidence intervals. Confidence intervals help us to understand the range of variability or uncertainty in either a measure of association or a measure of disease occurrence. Sometimes you might see a measure of disease occurrence or a measure of association accompanied by a confidence interval. And what does this mean? Confidence intervals are a statistical construct that provide us with information about a range in which the true value lies with a certain degree of probability, as well as information about the direction and strength of the effect. The confidence interval calculated from a sample is interpreted as a range of values which contains the true population value with the probability specified. It is the range of values estimated from a sample within which the true population value is likely to be found. Since we don't know the true value of, say, a risk ratio or an odds ratio, we calculate their estimates using a sample. Confidence intervals let us know how much our estimates of these measures of association might vary. We can answer the question, what is the range of uncertainty about our estimate? 95% is a commonly used confidence interval. However, sometimes you might also see 90 or 99% confidence intervals. A 95% confidence interval means that there is a 5% probability that the true population value lies outside of this range. Confidence intervals are used to indicate the reliability of the estimated result. Here is the mathematical formula for calculating 95% confidence intervals. And confidence interval is equal to the measure of association plus or minus 1.96 times standard error of the point estimate. The measure of association or occurrence could be a risk ratio, a prevalence, odds ratio, or some other value measure of association or occurrence. You take that estimate and then subtract 1.96 times the standard error of the point estimate to get the lower 95% confidence bound. To get the upper confidence bound, you add 1.96 times standard error. Note that the 1.96 is specific to the 95% aspect of the confidence interval. If you wanted to calculate the 99% confidence interval, you would use the number 2.575. And for a 90% confidence interval, you would use the number 1.645. Since this is an introductory epidemiology class, we are not going to get into the details of how to calculate the confidence intervals by hand. Mathematically, it is possible to do so. The point estimate, that is the risk ratio, odds ratio, will always be somewhere between your upper and lower boundaries. If it isn't, this is a good indicator that something went wrong in your calculation. For beginning epidemiology students, there are free software available that you can use to calculate 95% confidence intervals. These include OpenEpi and EpiSheet. Using either of these spreadsheets, you can plug in the numbers for each of the 4 cells in a 2x2 table. These spreadsheets then calculate the standard error and the related 95% confidence intervals. So what is a p-value? Study results are a combination of real effects and chance. A p-value is a probability that your study results are due to chance. P-values alone do not let us directly say anything about the direction or size of a difference or measure of association between different groups. So what do the p-value and 95% confidence interval tell us? Well, first we know that the 95% confidence interval has a relationship with the p-value. And if the 95% confidence interval does not include the null value, it is statistically significant. When the p-value is less than the alpha, which is usually chosen as 0.05, it is statistically significant also. So when you have a statistically significant result, it means that you can reject the null hypothesis and that there is no association between the exposure and the health outcome. Confidence intervals contain more information than p-value. The confidence interval also tells us the magnitude of the association between the exposure and the disease. It also tells us about the precision of the estimate we obtained. The narrower the confidence interval, the more precise the estimate. A clear distinction must be made between statistical significance and clinical relevance in epidemiological studies. The same numerical value for the results may be statistically significant if a large sample size was used, and not significant if the sample size was smaller. However, study results of clinical relevance are not automatically unimportant just because there is no statistical significance. So let's look at these 95% confidence interval examples. The first is an odds ratio of 1.5, 95% confidence interval of 0.7 to 1.7. We can see the second and the third. Which of these confidence intervals is or are statistically significant? Which is the most precise? And another question to think about, are narrower confidence intervals more significant? So the confidence interval does not cross the null value, in this case 1, which is 1, because we are talking about a ratio measure, then the confidence interval is statistically significant. So the C is statistically significant because it does not cross the null value. A and B cross the null value. B is a more precise confidence interval compared with A and C because the confidence interval is narrower or smaller. As A is the widest interval of these three examples, it is the least precise confidence interval. So while B is a more precise estimate, it is not statistically significant because it includes a null value of 1.